Chương trình hội thảo xin được phép bắt đầu. Lời đầu tiên, thay
Let's
mặt
begin now. First of all, on behalf of the organizers, we would like to welcome First of all, on behalf of the organizers, we would like to welcome and thank you for everybody for taking time out of your hectic schedule to attend this webinar. Ladies and gentlemen, with the permission of Vargo, based in healthcare in Vietnam, working together with Vargo, organizing this webinar focusing on evidence-based management of recurrent miscarriage and prevention of preterm labor. Attending our meeting today, it is our great pleasure to introduce to you our four leading distinguished guests at home and abroad. Our chairman, Professor Dr. Nguyen Tien, President of Vietnam Association of Gynecology and Obstetrics, former Deputy Minister of Health. Our speaker, Professor Gian Carlo Di Renzo, past Secretary General of the International Federation of Gynecology and Obstetrics, Director of Morbidity and Perinatal Medicine Center, University of Perugia, Italy. The second speaker, Associate Professor Shilpa Nambiar, Chairman, Malaysian Representative Committee, Royal College of Obstetrician and Gynecology, UK. Last but not least, Dr. Quang, Director of the U Hospital, Vice President of Perinatal and Neonatal Association. We would like to welcome more than 500 participants from all over the country. And now we would like to invite Professor Tien to deliver the welcome remarks. The podium is yours, sir. Ladies and gentlemen, distinguished guests, panelists, and speakers, today it is our great pleasure to attend this webinar focusing on a very important issues that we have to face on a daily basis: recurrent pregnancy loss and prevention of preterm birth. On behalf of the organizing committee, we would like to thank Basin Healthcare for working together with Vargo to organize this important event. I also would like to thank Professor Dr. Gian Carlo Di Renzo from FIGO and University of Perugia, together with Professor Shilpa Nambiar, Chairman, Malaysian Representative Committee, Royal College of Obstetrician and Gynecologist, Fellow FIGO, and Dr. Lê Quang Thanh, the U Hospital Director, as well as Vice President of Partner. As you may know, recurrent pregnancy loss and preterm birth in the world and also in Vietnam, the percentage is about 2%. So 2 or 3 cases of RPL out of 100 cases of pregnancy. RPL definitions when we have at least 2 pregnancy loss, one after another. And as for preterm birth, normal childbirth is more than 22 weeks. Previously, before 37 weeks. The more preterm birth, the more complications. We have been able to treat many cases of RPL and preterm birth, but even until today, we need to have an evidence-based medicine and the approach. I mean that we cannot understand the whole etiology, many cases of preterm birth, despite the fact that we have done quite a few lab tests, but we don't know why it is so. And every day, on a daily basis, we have to face, we have to diagnose, manage, and monitoring. And of course, many doctors, many healthcare professionals in treating. And today we enjoy our two distinguished guests talking about RPL and preterm birth. There are quite a few different opinions on preterm birth, when and how to use medications and using for how long. I'm sure that our three speakers today would help us to get more enlightened and gain the hands-on clinical experience for our daily clinical practice. Last but not least, I would like to thank our two foreign speakers and a local one to be here with us today. Preparation and a very good thank you goes to Basin Healthcare for organizing this important webinar. And now, without further ado, I would like to call upon Professor Gian Carlo Di Renzo to deliver the first topic. The podium is yours, sirs.
Thank you very much, Professor Tien. It's a big pleasure to see you. Unfortunately, not in presence. I would like very much to be in your country. I hope that you hear me, and I will try to share my slide as soon as possible in order to start my presentation. I also thank the presence of Professor Le Quang Thanh. Both Professor Tien and Le Quang Thanh are long-standing friends. I visited Vietnam many times. And this time we have to use our powerful computer tools and webinars to be connected. But I hope next year we can be together again. Today, I give my best regards to all the Vietnamese colleagues which are connected. Good afternoon to everybody. I'm speaking from the city of Perugia. You can see the images on the high left. It's a very old city with a very old university, more than 700 years old. And today I'm dealing with, as announced by Professor Tien, or recurrent miscarriage. The terminology of recurrent miscarriage has changed recently, especially because American Fertility Society has defined recurrent miscarriage as more than 2 miscarriages, while in the past it was more than 3 consecutive or not miscarriages. This is because this is a big burden for the population, create a lot of anxiety, and those couples who have experienced this kind of problems have a high chance to be depressed after. And you know, either the spontaneous miscarriage, is a recurrent miscarriage, is coming to be a big problem, especially nowadays, the worst and high industrialized countries, because number of pregnancy has diminished and the age of a woman is later than before, and therefore they are urging to make a workup in order to understand which are the reasons for late pregnancy loss. In any case, this kind of problem is emotionally very frustrating, and frustration sometimes results in recommendation of unsubstantiated tests and therapies of dubious efficacy. So doctors are mostly pushed to do something, otherwise patients are not satisfied and they change doctor and go another place, try to find some solution. We know that the risk of miscarriage is increasing by the number of previous miscarriages which are experienced by a woman. As you can see here, some of the most recent paper which evaluate recurrence risk is going up to 9 times when we have more than 3 miscarriages before, which in terms of percentage of risk, as you can see here in this publication, which I've recently done in the American Journal, means that if one woman experiences 2 or 3 periods of miscarriages, there is at least 40 to 60% chance that these will be repeated. Now, the etiological mechanism historically presumed for recurrent pregnancy loss are many. These are summarized in major points like genetic factors, anatomic factors, endocrine factors, infectious, immunologic problems, and some miscellaneous factors, which are, by the way, increasing because particularly environment has been linked more and more recently to the recurrence of pregnancy loss. But it is very difficult to find in any scientific society in any region of the world a homogeneous trend for suggesting specific exam in this case. This is workup that we usually is being suggested and is carried out, for instance, in my clinic. We do usually the karyotype, the couple, we evaluate the uterine cavity, we do some immunological tests. We know that, for instance, lupus anticoagulant and antiphospholipid syndrome is one of the single most prominent etiologies of recurrent miscarriage, accounting for almost 10% of all the cases that are described in literature. But don't forget the increasing role of endocrinology problems like thyroid, diabetes, lack of progesterone, and so on. And don't forget diet and lifestyle. Particularly now that obesity is increasing, we are not eating as well as in the past, and there are some new concepts coming now, particularly with omics. This is the most recent data I have, my clinic of recurrent miscarriage. You see that the recurrence of miscarriage by genetic causes is much less important than one that is due to immunological or endocrinological problems. However, I should say that even an extensive workup may sometimes will fail to find a recognizable cause in almost 30 to 40% of cases. Now, in the very recent 20 years, the role of progesterone has increased because our knowledge on the biological effect of progesterone in pregnancy have been much better elucidated. We know that low progesterone levels in pregnancy is associated with treated spontaneous miscarriage. However, there was not much clearness about the role of progesterone in maintaining a pregnancy, which are the major effect. And you know that natural progesterone has a lot of pharmacodynamics effect which are in keeping, especially in the role that it may have in the beginning of pregnancy, modulating maternal immune response, improving uteroplacental circulation, decreasing the prostaglandin effect which may rise because of stress. Stress, CRH hormone is a hormone stress. Of course, natural progesterone reduces uterine contractility, antagonizing oxytocin receptor, and is a potent anti-inflammatory drug. All these effects are possessed by the natural progesterone. But we have to remind that, especially in the last 30, 40 years, many synthetic compounds with a similar progestation action have been put in the market in our pharmacopoeia. But it doesn't mean they have the same effect pharmacodynamic of the progesterone. Synthetic analogs of progesterone have been developed to make the hormone available orally, because natural progesterone, until its microionization, was not available and well absorbed by gastrointestinal tract. They were developed mainly for contraceptive use, but we have to understand that they have different roles, and sometimes they are only having a small role in the endometrial pelvic area. So we have not to mix pear with apples. What I want to mean before starting to enter in details of a clinical management. When we look at the meta-analysis which have been produced in the last 10, 15 years dealing with different aspects of progesterone role in pregnancy, we have to be very careful to read if there is a quality in the data which are taken for the evaluation of meta-analysis, and if the conclusions are reliable according to the data. As you can see here, one of the most cited papers on the role of progesterone in treating a miscarriage, for instance, has a lot of bias. Many papers are very old and have a lot of bias and inclusion criteria and so on. And these studies of poor methodological quality don't give a good result. And they mix a lot of time, apple and pears, in mixing the natural progesterone with the progestogens, which have not the same effect, particularly at the beginning of pregnancy. And although it is apparent that progesterone may work in helping to avoid treating a miscarriage or even recurrent miscarriage, the data are very sparse. The data are coming from 50 to 60 years old studies, and I think that they should not be taken too much in proper account. Coming back to the major studies which have been produced in the last couple of years and published in important international journals, we have two major studies coming from UK. One is devoted to prevention of recurrent miscarriage through the role of progesterone, and the other is a rescue study which is looking at the role of progesterone in the treatment of miscarriage, which is a very frequent problem that we face in our outpatient clinic almost every day. This study is called PROMISE and PRISM according to the acronym, but I would like to point out two things. One, the number of patients which have been enrolled in these studies, which are very high. Just think about recurrent miscarriage, they enclose 800 patients randomized. And the second big point is the amount of progesterone which has been given, which has not been the case of the previous studies. In this study, the amount of progesterone was 800 milligrams per day. Okay, and this is a right big amount compared to the previous one. The very crude result of these two studies show a small beneficial effect only when we have a high number of miscarriages in the history of that patient. Apparently, the two groups were not too much different on the rest. The second study, which was looking to the early pregnancy bleeding, was randomizing more than 4,000 patients, which is 5 times higher than all the meta-analyses which have been done as number just published before. And this again show that even apparently there are not too much difference between the two groups. Those women who had experienced at least one previous abortion and they have bleeding now, they benefit of progesterone. These are the crude data. But let's now evaluate a little bit more and let's make a discussion about this result in agreement with the rest of literature. One of the most important things to recall is this slide. The majority of miscarriages, or at least the first miscarriages up to 2, is due to an abnormal fetal karyotype. Okay? More than 60%. It has been now well agreed. But when we increase the number of miscarriages, then the importance of fetal karyotype decreases compared to the normality of fetal karyotype and the influence of other etiologies. So more than 3 or 4 losses now we have a consistent number of pregnancy which can be saved, because it is impossible to save a pregnancy when there is an abnormal fetal karyotype. We don't do anything good. This is something that should be taken very well into consideration. If we look at data combining PROMIS and PRIV studies, so more than 5,000 patients, you see that there is an effect of progesterone in beneficial in women we had previous miscarriages. And looking at the live birth with the meta-analysis we produced in the American Journal at the beginning of the year, this is quite convincing, because we put together more than 4,500 cases and not the 100, 150 of the previous meta-analysis. So it's quite clear from this data, and now we have a much more interesting also meta-analysis come from 82 articles, that if I have more than one abortion previously and I start my therapy during the luteal phase, I do have a benefit in prevention of the subsequent miscarriage. So there are two information that we get from all this data. One published with 5,000 women, and the other putting together 26,000 women. The 26,000 women say we should start in the luteal phase to save a pregnancy. The other say we should have at least one abortion to be successful, at least according to evidence-based medicine. And this is made as a guidelines from the European Society of Human Reproduction, which at the end of 2017 said in order to have success with the progesterone, you have to start in the luteal phase. Now, therefore, the recommendation of giving natural progesterone, of course, is that there is a benefit in recurrent miscarriage when we start the substance and the therapy in the luteal phase. There is a piece of information very interesting. There are several studies now coming out, but this piece of information is telling you why it's important to start in luteal phase. Progesterone is imprinting the passage from endometrium to the deciduum. And this passage is not just an histological modification. There is a lot of modification in enzymatic activity. Just take the expression of N-cycling E, which has been evaluated by the group of Stephenson in Chicago in IVF patients, and you see that the expression of N-cyclic E is decreased by progesterone in order to make a successful implantation. And you can see here that patients with low progesterone or no progesterone have high cyclic E and no implantation. Patients with normal progesterone or with additional progesterone in the luteal phase have N-cyclic E decrease and a good implantation. And if we put this randomized trial, which has been published a couple of years ago, looking at 400 patients again with 800 milligram progesterone. So I would like to point it out that the amount of progesterone should be very high at the beginning, and not just 100, 200 as we gave in the past, and continue until 28 weeks. We have repress of the cytokine, which are inflammatory cytokine, and we prolong gestation, and we have a successful end of gestation. And these start again during the luteal phase. So we have two very big important piece of information. One, progesterone micronized should be starting luteal phase and reduce the rate of not only recurrent miscarriage, but also preterm birth. Secondly, we should give to at least a patient with a previous one pregnancy loss. Let me address just a couple of minutes the problem of safety of progesterone. We are giving very high dosage, very early pregnancy. Is it dangerous? There is all now literature that is very well concerning the drug safety of micronized progesterone and the cleaning micronized progesterone by any role in affecting the development of a fetus. So whatever is the amount of progesterone we give, at least until 1 gram, there is no risk of congenital abnormalities or so on. And also, the long-term effect of progesterone after pregnancy in the newborn has been evaluated 3 to 6 years of age in this big study from Scotland. You know, at least 250 babies follow up. There is no difference, okay? We have, however, some concern on the progestogens side, because natural progesterone is one thing, as I said, is an apple, and progesterone is something else, which is a pear. And we have to be careful because we cannot translate the result of one to the other. And there is a concern about safety on progestogen, particularly dihydrogesterone. Dihydrogesterone has been found already in a study in 2015, published in the Lancet, to increase the risk of congenital heart disease. But more recently, there is a Malarisk International group chaired by Professor Gian Carlo from Tel Aviv, which has looked to 2.5 million patient database, okay? And he found, published in Prenatal Cardiology, an increase again linked to dihydrogesterone early in pregnancy of congenital heart disease, not only, but also spina bifida, okay? This is an important concern we have to take into consideration. Let me make some conclusion and take home messages. So we know, and we have the biological plausibility that progesterone works in protecting pregnancy, and if started in luteal phase support in recurrent miscarriage is efficient, is safe for the mother and the fetus. If the current recommendation based on evidence-based medicine, meta-analysis which not mix pears with apples, as Professor Viet has suggested in his opening, we have patients with the first trimester vaginal bleeding, which had at least one previous miscarriage, benefit of 800 milligram day until 20 weeks of progesterone. We optionally can continue later if the patient is also having risk factor for preterm birth. Patient with recurrent miscarriage should start taking progesterone, 800 milligram in the luteal phase. Okay, that is important. And of course, those with the short cervix, but my friend Professor Shilpa will talk about this, may benefit of less progesterone because we start at already 20 weeks. So in the first 20 weeks, progesterone should be at high dosage. I would like to thank you for your attention. I hope to be convincing that nowadays we have evidence to use appropriate progesterone and appropriate dosage of progesterone for preventing recurrent miscarriage and also preventing the bleeding in pregnancy after a patient had one previous miscarriage. Thank you for your attention.
Xin trân trọng cảm ơn giáo sư Gian Carlo đã chia sẻ cho chúng ta khá nhiều thông tin hữu ích về chủ đề
for sharing with us a lot of information in terms of RPL management. Continuing the program, I would like to call upon the second speaker, Professor Shilpa Nambiar, Chairman, Malaysian Representative Committee, Royal College of OBGY, with the second topic. Professor Shilpa Nambiar, the podium is yours.
Thank you very much for this invitation to speak at today's webinar. Like Professor Di Renzo, I wish I were there, but unfortunately, because of COVID, we all have to deal with just web presence. Just 1 second, let me get, is my resume share? Okay. Okay, so continuing on from Professor Di Renzo, who's talking about recurrent miscarriage, I'm going to be talking to you about progesterone's role in preterm birth. So my topic is from updated evidence-based medicine to clinical practice. Now, preterm birth is something we see every day as well. And if you Google preterm birth, you might get some nice pictures of tiny babies like this, or you might get some stories of famous people who were born preterm but survived and became great. But being doctors and seeing firsthand, we know that not all preterm babies grow up to be geniuses or prime ministers. In fact, a lot of these preterm babies spend many months in neonatal intensive care, struggling for their life, and end up with all sorts of complications like blindness, deafness, long-term lung problems, and worst of all, cerebral palsy, which is what the baby and the parents have to live with. And the reason we're so worried is because this is still a big worldwide problem. Every year, 15 million babies are born before 37 completed weeks. And it's a dramatic difference depending on where you were born. If this baby was born in a low-income country, like in sub-Saharan Africa, the survival is only 10%. But if this baby was lucky enough to be born in a high-income country with all the facilities, then the survival is 90%. But regardless of all this, preterm birth complications are still responsible for about 1 million deaths under 5 years of age. And the sad thing is that 3/4 of them could be saved with current cost-effective interventions. That means tools that we have at our disposal right now. The rate of preterm birth varies from country to country, between 5 to 18%. Even a country like the US has got a 13% rate. And so even the WHO has published in 2012 a global action report on preterm birth, talking about recommendations to improve its outcome. And these recommendations include how do we predict and prevent preterm birth. So no matter where we are and whatever resources we have, we must try to do everything in our capacity to prevent our babies from suffering or dying because they were born too early. Unfortunately, to solve a problem, we must first understand it. And preterm birth is a very poorly understood problem. Because for one thing, if you looked at risk factors, 2/3 of them are associated with risk factors without any biological basis. For example, why is it that a baby boy is more likely to be born preterm than a baby girl? And some of these risk factors are not amenable to change. So you can't change characteristics of a woman. Let's say if she happens to be 40 years old when she gets pregnant, or being in her first pregnancies, both risk factors for preterm birth. And despite all the risk factor lists that we can look at, prediction can only pick up less than 50% of people who will end up delivering preterm. What do we do know then? What we do know is that preterm birth is not one problem. It is in fact a preterm parturition syndrome, very well illustrated by Professor Romero. It is an outcome of different causes, different pathologies. And so when there are different things that cause preterm birth, like uterine overdistension for twin pregnancy or multiples, cervical disease if a woman has had procedures or surgery to the cervix, obviously the treatment is going to be different. And this is another slide to show how complicated preterm birth can be when there are so many different mechanisms leading to the final thing. And also that means that every woman first needs to be identified in terms of what her cause was before we can decide what the right option would be for treatment. And so the biggest problem that we've had all this time is thinking that one medication will treat all causes of preterm birth. One size does not fit all. And this is where We've made mistakes like previously comparing pears and apples. You cannot treat women all the same if their problem is different. And so where does that leave us? Just very confused. So what I'm going to try and do over the next 15-20 minutes is try to organize this very big topic in how to approach preterm birth practically. And I'm only going to focus on the group where we can be most effective, not focus on everything. And I will also try to summarize some worldwide guidelines, because this is where the best evidence is what translates into guidelines, and give a few clinical cases if we have time. So, preterm birth. You have to divide it, of course, into iatrogenic or spontaneous preterm birth. Now, iatrogenic preterm birth is when we, the doctor, has decided that delivery is the safest option for either the mother, baby, or both. So this is usually because of a medical problem like preeclampsia or gestational diabetes, which is uncontrolled, or infection and chorioamnionitis. So I'm not going to talk about preventing this group because the treatment is completely different. We all have our different unit protocols on how to manage iatrogenic preterm birth, so we won't focus on it. And when we talk about spontaneous preterm birth, we also have to divide this into those with pre-labor, premature rupture of membranes, and those without PPROM. Now, I'm also not going to talk about PPROM spontaneous labor because as far as we know, even though there's been a lot of research into trying to look at women in the first trimester to see who is ultimately going to have PPROM, there is currently no effective prediction. And what we need to do is to treat to delay the pregnancy as safely as possible to viability or to a point where the baby can survive, and prevention of morbidity. And of course, the third group, the spontaneous preterm birth without PPROM. Now, this is where I'm going to spend most of my time, because this is where we can really talk about screening and prevention of this preterm birth, and then a little bit about how to prevent the morbidity if we can no longer prevent it. And this is where most of my talk is going to be focused on. But just before that, I just want to summarize some evidence-based practice for iatrogenic preterm birth. It's not that we cannot do anything at all. There are guidelines to say that yes, if we have good practice in trying to eliminate early elective deliveries, for example. So let's say a mother wants to have a cesarean section on the 9th of September 2020 because it's a nice number. We should at least have the responsibility to ensure that that baby is at least 38 to 39 weeks and not 36 plus just because it's a nice day. There should be regulated artificial reproductive techniques and IVF, movement towards single embryo transfer so there are no complications from multiple pregnancies, which is inevitable when infertility treatment is given. Medical problems are a big part of causing preterm labor iatrogenically. So if we can try and get these women pre-pregnancy, trying to optimize their medical conditions during the pregnancy, we can try to delay the delivery to as close to term as possible. And aspirin has been the biggest game changer in the last few years. There is a FIGO best practice guideline talking about aspirin as starting as before 12 weeks. And this can effectively reduce preeclampsia in high-risk women by 80%. And we also know that there is evidence to reduce preterm birth by between 20 to 40%. So let's talk about the group we wanted to talk about. Why do we want to predict preterm birth? Well, one, because then we are one up on dealing with the problem. The short-term advantages of prediction are, so we know who needs to be admitted and who can go home, who may need corticosteroids for lung maturity or magnesium sulfate. And for those of whom we are screening, if they are completely asymptomatic, there are things that we can try to institute, things like changing their behavior, stopping smoking, because we know that can reduce preterm birth. And of course, now we have prophylactic progesterone, cerclage, pessary, all tools that we may not have had some time ago. So how do we predict then preterm birth? How would we know who is going to go into labor early? Like I said, we have a whole list of risk factors, not all of which we can change, but definitely the biggest risk factor for preterm birth is someone with a previous preterm birth. Unfortunately, a woman will need to go through this once before we can effectively help her. But that seems to be the biggest predictor. And of course, we have the tools of doing a transvaginal ultrasound measuring cervical length. Now, this is something objective, not just a risk factor. And thankfully, there was a systematic review published a few years ago, which compared whether a transvaginal ultrasound single measurement between 18 to 20 weeks was better, or whether screening them serially was better. And thankfully for us, the conclusion was that one single cervical length measurement between 18 to 24 weeks is a better test to predict preterm birth that changes over time. And the cutoff that they use for singleton pregnancies is 25 millimeters and 15 millimeters for multiple pregnancies. So this is easy. People can be trained to do this ultrasound. You can do it at the same time as your detailed anomaly scan. And so it's giving us extra information on how to go on with that pregnancy. And these are now the tools that we have. A pessary is one of the newest tools. Progesterone we've always had, but we now know that there is more evidence for it to prevent preterm labor and maybe even more effective than the others. And cerclage, although this was the only tool that we had over the last 50 years, we're finding that it is used less and less because the other two options are more attractive. And of all these three, the evidence points towards vaginal progesterone. And in fact, this is how progesterone has made its way into guidelines because of the evidence. And we find that progesterone works best if a woman has had a previous preterm birth or if she has a short cervix. Other things that we can try to do to prevent a preterm birth is to try and eliminate maternal smoking and try to space pregnancy for more than 18 months because that seems to be effective as well. And this is a nice guideline that summarizes how we can approach someone that we think may go into labor early. So if you think that a woman is at risk and she's got a cervical length of less than 25 millimeters, you try to triage that into the type of history. If her history is that she's got a previous spontaneous preterm birth between 16 to 34 weeks, then you offer her prophylactic progesterone or a cervical cerclage, but medication always is better than something invasive, especially if it works so well. Now, if the history is that she's got previous PPROM or a history of cervical trauma, which is LEDs or a cone biopsy to the cervix, maybe cervical tears during delivery, extended tears, then because it's an anatomical problem, they advise you to consider a cervical cerclage instead. Now, if a woman didn't have any history at all and just had a vaginal ultrasound revealing that she has a short cervix, prophylactic progesterone is what you should recommend. But when we compare all these different modalities in a singleton pregnancy of women who are at risk, the conclusion from this network meta-analysis was that vaginal progesterone was the only intervention with consistent effectiveness at preventing preterm birth in singletons and overall and in those with preterm births. And it was that pessary or oral progesterone showed similar results, but I'll explain to you why a vaginal progesterone is much better. What does it do? Now, we've already heard how important progesterone is in maintaining pregnancy in the beginning and how we need to use really high doses in the first trimester. But it is the pregnancy hormone. Apart from luteal support, it converts the endometrium to the secretory phase. It modulates the maternal immune response to allow acceptance of the fetus so it's not rejected. and it keeps the uterus quiet, reduces smooth muscle contractions, or reduces contractions. And we also know that withdrawal of progesterone is what leads to labor. So for those of whom you don't want to labor, you give progesterone continuously. There are different routes of administration: intramuscular, which gives you 2 high doses, oral, and vaginal. But of all the 3 administrative methods, it is vaginal progesterone that has the most targeted delivery, and it avoids the first pass metabolism to the liver, where it can inactivate some of its action. And because of this is the progesterone that is most effective at preventing preterm labor. But we also want to know whether it is safe to continue administering progesterone. Professor Di Renzo has already talked about how there is no effect in terms of abnormalities to the fetus. But what we want to know is whether it is safe for development. And this is a study that showed the long-term effects of prenatal progesterone on the neurophysiological development in twins up to 8 years of age. And we found that when this questionnaire was given, it seemed that those who had progesterone had a higher ASQ score, and which means that their cognitive development was much better. So apart from this prevention of preterm birth, progesterone also seems to protect the fetal brain. We go back to the evidence for prophylactic progesterone. Now, this is also some studies which were summarized in the video that was showed before the presentation started. But at the end of it, it shows that vaginal progesterone is the most effective and as effective as cervical cerclage to prevent preterm birth and adverse perinatal outcomes. This is an individual patient data, which means it is even better than a meta-analysis, looking at different studies, looking at progesterone prevention of preterm birth over the years, including the Optimum study in 2016. And when it is all combined, it seems that if we administer vaginal progesterone, there is a risk reduction of about 40%, which is significant and certainly enough for us to consider using it in our daily practice. And because of this, guidelines are now recommending vaginal progesterone. But apart from vaginal progesterone, other interventions to prevent morbidity are already now more established. We know that antenatal corticosteroids are important in preventing respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis. But what's new is that timing is more important than we thought. Just giving 1 dose and then hoping that it will work for the next few weeks is no longer enough. And so in fact, there is now a window in which antenatal corticosteroids should be given. Do not give it until you are absolutely sure that these women are going to deliver within 7 days, 24 hours to 7 days from administration, because the composite morbidity outside of this window doesn't seem to be any better. The ideal time, of course, is between 24 to 34. Earlier than that, it may not be effective, so you may need to repeat the dose. After 34, the only guideline that recommends it is the American College, but you will consider it in certain cases if the woman is diabetic, where we know maturation takes a little bit longer, but timing is more important than we thought. The other important intervention to prevent morbidity from preterm birth is magnesium sulfate. The first Cochrane review in 2009 found that it significantly reduced cerebral palsy and gross motor development in babies who were born under 37 weeks. But since then, this has been updated and it has made its way into several guidelines around the world. Most countries will recommend giving magnesium sulfate the same way we give it to prevent eclampsia, the 4-gram bolus followed by a 1 gram per hour until delivery, especially if the baby is between 30 or less than 32 weeks. Because after that, the area of the brain that is vulnerable to intraventricular hemorrhage is no longer there. So this is just a representation of when you would consider giving magnesium sulfate and corticosteroids, but this is already well known, so I won't spend very much time on it. Rescue cerclage is something that's very difficult to administer and is slowly losing favor around the world. Now, this is a table to summarize all the interventions that we use commonly in our practice. We've used magnesium sulfate for decades to prevent preeclampsia. But if you look at the effect, you need to treat 100 women to prevent one case of eclampsia. But giving magnesium sulfate to prevent cerebral palsy for babies born before 34 weeks, the number needed to treat goes down to 52, which means we are benefiting more women by giving it. And we're already familiar with how we give it with our practice with eclampsia. Antenatal corticosteroids, also something that we've been using for a long time, have even lower NNTs. 11 people to prevent one case of RDS, 22 cases to prevent one case of neonatal death. And so now, with all the updated evidence, you can see that giving vaginal progesterone in a short cervix to prevent preterm birth before 33 weeks, you need to only treat 11 women to prevent one preterm birth and 18 women to prevent one RDS. So when this intervention seems to be so useful, you really must think twice for why you're not using it more often. Now, this is a list that I found very useful. Zakur Alfirevic and his group looked at different guidelines for preterm birth around the world. So this was a list that made it in every single guideline. So that means that these recommendations have enough evidence and grade 1 evidence so that everyone is recommending the same thing. And so cervical length screening for high-risk women. Now, they suggest high-risk women only because if you screened everyone, obviously it's very good to screen if you get a long cervix, knowing that the negative predictive value is almost 99%. But finding a short cervix in a woman with no history may not necessarily lead to a preterm birth. And then you've caused unnecessary worry, unnecessary medication. So they've recommended that high-risk women be screened. And if there is a short cervix, then there's definitely a place for vaginal progesterone. Screening for asymptomatic bacteriuria, because we know treatment of asymptomatic bacteria prevents pyelonephritis and the subsequent preterm birth. Tocolysis is only for the short term, usually for transfer to a facility with facilities for preterm birth or to complete corticosteroids. Magnesium sulfate for neuroprotection, as we talked about earlier. Antibiotics for PPROM, and vaginal progesterone for asymptomatic with cervical lengths of less than 20 millimeters before 24 weeks. They recommend cerclage for multiple pregnancy losses, but ACOG, even one or more loss is an indication for cerclage. Antenatal steroids, which we've talked about before. Transabdominal cerclage only if the previous cervical cerclage was unsuccessful. But despite what people have been recommended for singleton pregnancies, there are no guidelines for effective management in strategies in multiple pregnancies. So we just have to wait for more evidence. This is a conclusion for in one of the American College guidelines, which is now suggesting progesterone be given for prevention of preterm birth at a dose of 200 milligrams if it's a singleton pregnancy, 400 milligrams for multiple pregnancies. They've asked to avoid intramuscular hydroxyprogesterone caprate and prefer vaginal progesterone as the previous one increases neonatal adverse outcomes. And so this brings me to the end of my presentation. The summary is that preterm birth is a syndrome with different etiologies. There is a small group that we can treat and we can treat effectively. What we need is a stepwise approach of prediction, prevention, and reducing morbidity. Vaginal progesterone is highly effective at preventing preterm birth, especially in those with a previous preterm birth and those who have a short cervix. And it's important that we tailor care to the individual etiology to ensure the best outcome. Now, if we still have a little bit of time, I'm going to go to some cases so that we can just see how we've been using these strategies. Now, this is woman MDR. She was a 34-year-old woman in her 5th pregnancy, but only a para 1+3. She had hypothyroidism on thyroxine replacement, and this was her previous obstetric history. In 2013, she had an induction of labor at 41 weeks for intrauterine growth restriction. She delivered a 2.5 kilo baby girl. In 2015, she had a first trimester miscarriage with a surgical management. In 2015, the same year, she had a second first trimester miscarriage, which was spontaneous. So in 2017, at this point in her country in Spain, they started her on progesterone in the first trimester only and then stopped it after that. They gave her aspirin until 20 weeks and they put in a cervical cerclage at 14 weeks. But at 20 weeks, she went into labor. The cervical cerclage had to be removed. So she had a mid-trimester miscarriage and this baby passed away. So this is when I saw her. She came to see me in 2018 at 4 weeks period of amenorrhea with a pregnancy test of positive. Very, very, very anxious, of course. At 7 weeks, we confirmed the pregnancy and we started her on Iatrogenic vaginally, 200 milligrams at night. At 10 weeks, she had a fainting spell at church. So she came straight to hospital because she was really worried. But we discharged her because she was fine. At 12 weeks, the baby was growing fine. Her cervical length was 4 centimeters, so nothing to worry about at that time. At this point, we started her on aspirin, 100 milligrams at night. At 16 weeks, the parameters were 16 weeks. Her cervix was still long, despite her previous history. And then this is where the problem starts. At 18 weeks, the baby was a normal 18-week size, but the cervix was now 2.1 centimeters. So she was already on progesterone. What could we do? I increased it to twice a day vaginal progesterone. At 19 weeks, despite the vaginal progesterone, her cervix became even shorter. It was now 1.7 centimeters. And so we were worried and decided we needed to do something else. Inserted the Arabin pessary, advised her to rest at home. At 20 weeks, she came back to the clinic. The baby was growing fine. The cervix seemed to have grown a little bit. And she was reassured. At 21 weeks, she had a normal anomaly scan. The baby was 432 grams. She had a normal uterine artery Dopplers. The cervix now had funneling. But now we understand that funneling has no significance. Anyway, we were still worried. At 23 weeks, there was some fluid in the vagina. She felt fetal movements. The speculum just showed some whitish, watery discharge. She was admitted overnight just to confirm that it wasn't PPROM. Her CTG was normal. She had no contractions, no leaking. Cervical length was 1.4 centimeters. We saw some sludge, but the baby was still growing. No other signs of infection. And we let her go home. 3 days later, 23 weeks, oh, sorry, this is the same. The baby was 600 grams. Cervix was now 1.1 centimeters with the funneling. Of course, we continued to be worried. So without knowing what else to do, we admitted her for bed rest. Increased the progesterone to 3 times a day. Gave her antenatal steroids at 24 weeks because there was no point giving it any earlier. Do we give magnesium sulfate yet? Well, we decided not yet. 25 weeks, she had a deranged glucose tolerance test. The baby was 800 grams by now. Cervical length was better. Seemed like the bed rest was working. We gave her a dietitian referral for gestational diabetes. 26 weeks, baby growing, cervix now 2 centimeters long, no more funneling seen. 27 weeks, baby was above 1 kilos. She had good glycemic control on diet, and baby was in breech presentation. 28 weeks, started shortening again. Baby still growing. We gave her DTaP at this point. 29 weeks, the blood sugar control became not as good as it was before. So we started her on metformin. 30 weeks, 1.7 kilos, cervical length 1.7. The maximum vertical pull for the amniotic fluid was 4. At 31 weeks, the baby was only 1.8 and the os appeared open. The Doppler seemed a little bit suspicious, and so we decided to deliver the baby as the growth was static and the Dopplers were suspicious. At 32 weeks, baby was still about the same. Os was 1 to 2 centimeters open with the arabin in place. So we decided at 33 weeks to take it off. The os was 3 centimeters and we did a sweep, waiting to anticipate normal labor, but nothing happened. And so we induced her then with Prostin and Cervidil. It took a while to get her going, but then after that, after she went into labor, her first stage was 4 hours, second stage 20 minutes. She delivered a 1.89 kilo baby boy. Apgar was 9 and 10. Baby was only in NICU for 2 weeks, and not because of anything, but that he was not tolerating feeding, but discharged home after that. And my patient gave me permission to show you this picture with little Fernando in the middle because he's thriving and well. She had another pregnancy after that, similar course with a short cervix, vaginal progesterone, arabin pessary at 19 weeks. She got to 38 weeks and the same thing happened. The growth became static for 2 weeks. She had an induction of labor, but finally had a cesarean section because of a deflexed head. That baby boy is now 2 months old and healthy. At this pregnancy, she stayed home. She didn't need to be in hospital at all because of our previous experience. Second case. Now, this is a woman who is 39 years old, gravida 5, para 2+2. She had a first trimester miscarriage and ectopic pregnancy, but 2 full-term deliveries. These children were aged 14 and 6. She was admitted for 4 days at 7 weeks for hyperemesis gravidarum. 10 weeks, the baby was growing according to 10 weeks. The blood test that we did just showed some vitamin D deficiency, nothing more at that point. We did an NIPT. It showed a low risk fetus XY, admitted for 3 days with a urinary infection at 14 weeks, threatened miscarriage. And then again at 16 weeks for urinary tract infection. At 20 weeks, her GTT was done, which was normal. Baby was about 380 grams and she had a long cervix, so nothing more that we thought we needed to do. Normal anomaly scan after that at 21 weeks. The uterine artery Dopplers were also normal. And up till 25 weeks, everything was fine. Then she came in with heavy vaginal bleeding, admitted through emergency. When we did a speculum, it just looked like stale blood and the os was closed. The baby was 700 grams, but the liqua looked subjectively reduced. And at 26 weeks, she started coming in with bleeding with clots. The baby was about 1 kilo. Cervical length was still acceptable, 2.6 centimeters, but the liqua was definitely reduced with normal Dopplers. During admission, we confirmed that she had Preterm. So we started her on erythromycin, antenatal steroids, and vaginal progesterone at night, although with Preterm, it wasn't probably not the best thing to do. Stable for 2 days. We did a low vaginal culture on admission, which grew group B strep. So what do? Now we know she's got prolonged rupture with GBS. Do we deliver? Are we conservative? When do we give her magnesium sulfate? But nature answered the question for us. She developed contractions the next day. We gave her magnesium sulfate. What about mode of delivery? We did a cesarean section for chorioamnionitis. We delivered a 970 gram baby boy. Abgas 7-8 with meconium stain liqua intraoperatively. The baby was in NICU for almost 2 months, but now he is 2 years old with normal development, no complications, because we did everything we could to prevent this morbidity. And that comes to the end of my presentation. Are there any questions?
And the questions would come at the end.
Okay. Yeah. All right, then. Thank you very much, Vietnam.
Dạ.
Thank you for
Xin
your
trân trọng cảm
patience
ơn.
today.
Xin trân trọng cảm ơn Phó Giáo sư Bác sĩ Shilpa Nambiar đã
Many
chia sẻ.
thanks, the second speaker, for sharing the updated information, as well as two interesting clinical cases. The questions and answers would be dealt with at the end. Continuing the program, I would like to call upon Dr. Lê Quang Thanh, Director of the U Hospital, to deliver the last topic. The podium is yours, sir. Professor Di Renzo and Professor Nambiar, it is my great pleasure today to talk to you. We do hope that in the future, you are going to join with us the Vietnam Franco Symposium. We can have, it is going to be hosted at the end of October in Ho Chi Minh City. We do hope that everybody can join us in that meeting. To continue the program, I would like to share with you some of our clinical experience in Vietnam that we are using, especially in recurrent miscarriage and preterm birth management in Vietnam. As we know, clinical miscarriage depends quite a lot on the age of the women. For women between 20 to 30 years old, the percentage is between 9 to 17%. 40 years old, it may comes up to 40%, 45 years old, 80%. So younger than 30 years old. For every 5 pregnant women, one of them have pregnancy loss. Overview of recurrent miscarriage definition. Fetus is expelled from the uterus before 22 weeks, at least twice, one after another. Recurrent pregnancy loss is lower than other miscarriage in terms of etiology. Abnormal karyotype chromosome, abnormal anatomy, endocrine, lacking progesterone, immune factors, coagulation disorders, infections, environment, and unknown causes. Sometimes, about 50% we don't know about the etiology. In terms of treatment, it must be based on etiology, prognosis, and prevention. It depends on the etiology. For example, if we lack endocrine, we need to provide supplementation, progesterone as early as possible in the luteal phase. We do not need to wait until positive pregnancy test. If there is cervical insufficiency, surplusage, antiphospholipid syndrome, low dose aspirin before conception, and anticoagulant during pregnancy, systemic disease such as thyroid disease, maternal and paternal karyotype, we need to provide genetic consultation. Risk of miscarriage would increase according to the number of previous miscarriage, prior history of miscarriage. The more previous miscarriage, the chance of miscarriage would increase. Sometimes we think that it is due to aneuploidy, but actually, the more previous miscarriage, aneuploidy miscarriage doesn't change. Meanwhile, euploidy miscarriage would increase. Therefore, that is the benefit of progesterone, which is beneficial. Natural brachythinized vaginal progesterone reduces significantly miscarriage and increases live birth rate in women with recurrent miscarriage. Luteal-phase early use of progesterone, 200 milligrams twice a day before pregnancy until 28 weeks versus placebo. Less miscarriage, less vaginal bleeding, less preterm birth, and increasing ongoing pregnancy and live birth rate. This study was published in 2018, showing the efficacy of natural vaginal progesterone. Another study in 2020 regarding cost effectiveness. If we use vaginal progesterone, what is the cost and benefit? 400 milligrams twice a day until week 16 in people with threatened miscarriage or previous miscarriage. We would be able to increase up to 8,450 live birth rate per year in the UK, based on the clinical trial Preterm in the UK. 3% in the UK. And every year it would increase up to 8,450, and it can save quite a lot. Many studies have shown that a lot of evidence in long term showing that progesterone is safe and efficacious. We can use from luteal phase until childbirth. In the whole pregnancy, the first trimester, second trimester, and the last trimester, there are quite a lot of risk factors. If we use progesterone in the whole pregnancy, it is still safe. Safety profile is quite strong. Progesterone, natural, micronized vaginal, can be safe for both mothers and fetus and does not increase congenital anomaly. Therefore, in conclusion, recurrent miscarriage treatment should be done according to etiology. For example, antiphospholipid, lacking hormonal, we need to provide supplementation. Progesterone starting from luteal phase to increase pregnancy, ongoing pregnancy, and live birth. Starting on day 17, and then ongoing until week 28, 1 to 2 tablets, 200 milligrams, twice a day in terms of safety. natural progesterone can be used safely for the whole pregnancy. That is what we are doing in Vietnam. Now let's move on to preterm birth. Preterm birth is a leading cause of neonatal mortality in Vietnam. In Vietnam, about 40 to 50% of neonatal mortality is due to preterm birth. In terms of global strategy, there are two global strategies: prevention of preterm birth. We need to do a good job to reduce preterm birth. And the second strategy is a neonatal care. The second strategy is good care of the preterm baby. If we do a good job in that field, we can reduce neonatal mortality. We need to combine the two-pronged strategy like that.
Tích cực điều trị dự phòng với progesterone thì tất cả các
When using progesterone, preterm birth would decline less than 37 weeks, 35 weeks, or even 32 weeks. So the strategy progesterone is really worthwhile. Regarding risk factor, there are two groups, maternal and fetal. Maternal, such as previous preterm birth, short cervix, acute disease, chronic disease, vaginal bleeding, uterine abnormalities, previous uterine surgery, hereditary, and lifestyle. The two big risk factors is previous preterm birth and short cervix, which has the biggest impact on preterm birth. Fetal, multiple pregnancy. So those three factors, as I have said, previous preterm birth, short cervix, and multiple pregnancy. Screening methodology for preterm birth. Cervical length is the strongest prognostic factor. It should be measured without contractions. It can be done routinely by using ultrasound between gestational week 19 to 23. For those with previous preterm birth, instead of waiting until week 19, it can be done between 14 and 16. If you already have uterine contractions, we would use the cervical length to prognosticate the chance within 7 days. There are three big risk factors: previous preterm birth, multiple pregnancy, and cervical length. Regarding the clinical guidelines in Vietnam, we introduced that in 2019. Level of evidence is A, cervical length, week 19 to week 23. Secondly, vaginal progesterone, when the cervical length is under 25 millimeter, equivalent to cerclage. Cerclage should be done in experienced facility. It is an invasive procedure. It should be done in well-equipped OBGYN facility. Vaginal progesterone, 200 milligram, micronized or 90 milligram gel form until week 36 or until labor or rupture of membrane. In Vietnam, neonatal care is not as good as other country, therefore we have to use it until week 36. Regarding progesterone, does it increase GDM? Natural progesterone reduces uterine contractions. Progestin cannot do that. So in terms of uterine contraction, uterine quiescence, natural progesterone is better. Natural progesterone does not lead to the risk of GDM. Meanwhile, progestin can lead to diabetes. We need to personalize the treatment. In singleton, preterm birth, based on the following factors. Without previous history of preterm birth, everything is normal. Cervical length between week 19 and week 24. When the cervical length is less than 25 millimeter, progesterone vaginally is indicated until week 36. The second scenario, one time a preterm birth or miscarriage, then progesterone vagina between week 16 to week 36, cervical length between week 16 to 24. The first group, week 19 to week 24. The second group, we need to measure the cervical length much earlier. And if cervical length is more than 25, we need to repeat that every 2 weeks. If cervical length is less than 25, then cerclage is indicated. This is prophylactic cerclage based on ultrasound findings. For people with at least 2 times a preterm birth or miscarriage, cerclage should be done between week 13 to 20 weeks. Prophylactic cerclage because of the obstetrical history, and vaginal progesterone between week 16 and 36. This is the protocol and regimen conducted in our hospital. In terms of sulfate, magnesium, in Vietnam, it is used quite often when preterm birth is prognosticated within 24 hours. Only use sulfate, magnesium to protect the brain and prevent cerebral palsy. If childbirth is predicted to happen within 24 hours, currently there are 3 regimens. Bolus, 4 grams, intravenously within 20 to 30 minutes, and then maintain 1 gram for every hour. The second regimen is similar. In our hospital, we would use 4 grams diluted intravenously within 20 and 30 minutes, single dose, no maintenance. It is protective. No matter how many fetus there is, any etiology, number of pregnancies, and no matter the previous vaginal or surgical delivery. Sulfate magnesium is neuroprotective when the corticosteroid or not, sulfate magnesium can be repeated within 24 hours when starting. Regarding corticosteroid, it can reduce respiratory distress syndrome, antenatal, quite safe for mother, beneficial for children, reducing the chance of respiratory failure, and at the same time, one episode after the first dose and 7 days without childbirth, we can repeat the second dose. If you use corticosteroid and after 7 days, the mother does not deliver the baby yet, after 7 days, you can repeat corticosteroid. Tocolytics. Tocolytics can help to delay the labor and delivery within 7 days. Tocolytics help delay childbirth within 7 days, but no effect on preterm birth and newborn outcome. Prophylactic antibiotics are recommended for early rupture of the membrane. The antibiotics which we use is erythromycin. In conclusion, as I have told you, in terms of prevention of preterm birth, consider risk factors, prior history, short cervix, monotherapy, vaginal progesterone, if there is only one risk factor, just history or just short cervix. When there are multiple risk factors, for example, prior history, short cervix, and multiple pregnancy, then we should combine vaginal progesterone, cervical cerclage, and pessary. Early use of vaginal progesterone, week 16 to week 36. We need to plan to remove stitches before labor. Women already in labor, we need to estimate the chance of preterm birth in 24 hours to protect the baby brain with sulfate magnesium, corticosteroid. Within seven days ahead, tocolytics. We can deliver prophylactic antibiotics if there is rupture of membrane. And there should be neonatal intensive care unit. Therefore, hospital which does not have a neonatal intensive care unit, they should refer the women to tertiary hospital. That is my presentation. Many thanks for the speaker for sharing with us the information. We would like to thank our 3 speakers. Now the floor is open. I have a question for Professor Di Renzo. Professor Gian Carlo has said that when we use natural progesterone for recurrent pregnancy loss, we we may use a natural progesterone 2 or 3 cycles even before getting pregnant. Can you elaborate on that? The second question.
But of course,
The second question. Wait a minute.
yeah.
The second question. When we use a high dose natural progesterone, you say that it is safe for mothers and baby and quite efficacious. Until week 36. So this high dose of progesterone, it is a female hormone. And if this is a baby boy, is there any study talking about the impact on the gender of the baby boy?
Okay. Can I answer? Two questions.
Yeah.
Correct? First one, of course, if you have a patient with a recurrent miscarriage and you propose to use progesterone since luteal phase, there could be few cycles in which you give progesterone and the patient is not yet pregnant. And this doesn't change anything. The important is to start at the time she's pregnant. Therefore, she has to, when she plans pregnancy, she should start progesterone high dosage 2 days after the mid-cycle intercourse and continue until either the test of pregnancy is positive and then continue until 20 weeks, or if it's not positive, withdraw progesterone and wait another cycle. And there is no problem to do this. The second, the dosage of progesterone up to 800 milligram or even to 1 gram has not been found, even by clearance of FDA, to affect the gender of the fetus. So there is no effect on the gender of fetus. Therefore, I think that everybody can be very sure that there is no safety concern in this regard.
Thank you. Có ai có câu hỏi gì không?
Are there any other questions?
Em xin mời đậu cầu ở Sài Gòn, các bạn marketing có thể đặt câu hỏi ở trên trên Zoom ạ, vì hiện nãy có rất nhiều bác sĩ đặt câu hỏi trên khung chat ạ.
Xin cảm ơn giáo sư Gian. Xin đọc
Many
một...
thanks to Professor Gian Carlo Di Renzo. I would like to read some other questions. There's one question going to Dr. Thanh. For people with the Preterm, if you want to maintain the pregnancy, then what kind of progesterone should you use? Many thanks for these questions. We usually, regarding the use of progesterone, there are different routes. Today, we talk mainly about vaginal route of administration. Sometimes you can use orally. For people with a lot of vaginal bleeding or Preterm, you can use orally. Or you can use progesterone and insert it into the anally rectal progesterone, intramuscular progesterone might be another option. So if you cannot put it into the vagina because of vaginal bleeding, you can use rectal progesterone, oral or intramuscular.
Có báo cáo viên có hỏi là Khi sử dụng progesterone
There's one question. Using progesterone to week 36, using progesterone to week 36, does it increase postnatal bleeding? This question goes to Professor Shilpa Nambiar.
Hello, thank you for that question. Yes, it's a good question because progesterone is supposed to be a muscle relaxant, but we only continue it till week 36, and the medication is washed out, and by the time women go into labor, that progesterone effect as a tocolysis does not even exist. So there is no increased PPH or uterine atony or anything like that, despite having used progesterone all to the end of 36 weeks. And most women may not even go into labor right after you stop the progesterone.
Vâng. Có người hỏi là với thông tin mới
There's another question regarding the side effects of dirogesterone. What is the national guideline regarding dirogesterone? Because many local doctors are using dirogesterone. Professor Gian Carlo has told us about the side effects and the different efficacy between progestin, synthetic progesterone, and natural progesterone. If you use a natural micronized vaginal progesterone, many studies with a large sample demonstrating safety for both the mothers and children, there are no safety signal like dirogesterone.
Well, we talked about dihydrogesterone with when Professor Di Renzo's talk. It was a first trimester use of dihydrogesterone, and that's when organogenesis is happening, and that's the potential for cardiac defects and all that. But this vaginal progesterone or progesterone usage for prevention of preterm birth, it was only vaginal progesterone that was effective, number one. So there's no question about starting them on oral progesterone after you've done an ultrasound, finding a short cervix, or getting a history of previous preterm birth. It is vaginal progesterone that is preferable. But in terms of whether it causes other side effects after its usage from the first trimester, I'm not aware of any.
Có bạn có hỏi là
There's another question. Supplementation of progesterone in luteal phase, does it increase ectopic pregnancy? I think that there's no study talking about ectopic pregnancy in using early progesterone. It takes the fertilized egg moving from just in a short time, and progesterone does not disrupt the peristalsis of the ovarian tube. Therefore, I think it would not increase ectopic pregnancy. I have read a lot of medical textbooks, and natural progesterone does not increase ectopic pregnancy. Many thanks to all the speakers. We still have quite a lot of questions. However, in the interest of time, we have to stop here. And we are going to provide you answers later. To all the participants, we would like to thank you all for your active participating in this meeting. And now I would like to ask Professor Tien to deliver the concluding remarks. First of all, I would like to thank our three speakers, Professor Gian Carlo Di Renzo, Professor Shilpa Nambiar, Dr. Thanh, for giving us a lot of information and sharing with us all of the valuable guidelines and clinical experience. In terms of recurrent miscarriage, pregnancy loss, and preterm birth, the more previous miscarriage, there would be the higher chance of miscarriage. Etiology is so much. Anatomy, karyotype, hereditary, coagulation disorders, genetic diseases, and so on. Many diseases such as thyroid disease, environment also affect on pregnancy loss. 40% we do not know the etiology. The role of progesterone in using from the early pregnancy until week 36 is quite valuable for anti-inflammation, circulation, anti-production of prostaglandin, and uterine quiescence, safety for both mothers and babies. When using progesterone, different formulations, different products are different from each other. Natural progesterone is different from progestin and progestogen. Many clinical trials with a big sample size in using progesterone at different doses. 800 milligrams a day divided into 2 doses. In all the routes of administration, vaginal and rectal, vaginal is the best. Less side effects, less systemic impact. We need to start as early as possible in the luteal phase. For IVF, right after oocyte retrieval. For people with previous history of recurrent miscarriage, prophylactic use is recommended.
Là chỉ dự phòng trong những trường hợp ví dụ như nghĩ rằng là sẽ có thể có thai thì ngay sau khi quan hệ đấy thì có thể là sử dụng rồi, mà lại sử dụng
You can
đấy,
use it.
không có thai thì thôi. Có nghĩa là vẫn là cái chủ trương là sử dụng rất sớm, sử dụng khi mà ở giai đoạn hoàng thể. Đấy thì còn về cái sinh non ấy thì nó hậu quả rất là nghiêm trọng, như ngay ở các nước cái tỷ lệ sinh non cũng vào khoảng đến 10%, mà đặc biệt trong cái giai đoạn hiện nay nữa thì với cái xu hướng mà làm cái hỗ trợ sinh sản thụ tinh trong ống nghiệm mở ra nhiều trung tâm làm thì cái tỷ lệ sinh non càng cao nếu như mà với chủ trương chúng ta không chuyển một phôi mà chuyển 2 phôi, 3 phôi, thậm chí nhiều hơn nữa thì cái nguy cơ đa thai và sinh non càng cao. Và hiện nay cũng tỷ lệ vào khoảng đã là 10%. Và đã sinh non như vậy thì nó có rất nhiều cái nguy cơ cho đứa trẻ. Đứa trẻ có thể bị mù, đứa trẻ có thể bị điếc, đứa trẻ có thể bị bại não, và càng sinh càng non thì cái nguy cơ đấy càng cao. Do đó để mà dự phòng sinh non thì vẫn là cái điều trị sớm về cái progesterone tự nhiên, và cái đường sử dụng tốt nhất vẫn là đường âm đạo và dùng càng sớm càng tốt. Và người ta cho rằng đối với những cái trường hợp mà sinh non như vậy thì có thể cũng do nhiều nguyên nhân đấy, nhưng mà người ta rất cần phải theo dõi về cái độ dài của cổ tử cung, và độ dài cổ tử cung thì cần phải siêu âm sớm, và đánh giá là độ dài cổ tử cung mà dưới 2,5 cm là ngắn, là nhiều nguy cơ, và cũng có nhiều nghiên cứu thì cho rằng là ngay cả những trường hợp cổ tử cung ngắn dưới 2,5 cm thì điều trị bằng cái progesterone tự nhiên đặt âm đạo nó vẫn mang lại hiệu quả rất tốt. Tuy nhiên, báo cáo của giáo sư Shilpa Nambiar thì cũng cho rằng là thậm chí dùng đường progesterone tự nhiên đặt âm đạo còn hiệu quả hơn so với khâu vòng cổ tử cung. Còn riêng tôi thì tôi cho rằng là nên phối hợp thì nó vẫn tăng cái hiệu quả giữ được thai hơn. Nếu như cổ tử cung ngắn thì chúng ta cũng mạnh dạn khâu vòng cổ tử cung kết hợp với progesterone tự nhiên bằng đường âm đạo. Chỉ trong trường hợp không sử dụng được đường âm đạo thì lúc đấy mới sử dụng đường khác, đấy là đường uống và đường tiêm. Tuy nhiên nếu cái đường uống, đường tiêm thì vừa bệnh nhân đau, phiền toái và cái tác dụng ít hơn, và còn một cái tác dụng phụ nữa là còn phải chuyển hóa qua gan. Đó là nếu như mà trong điều kiện cho phép thì đường âm đạo vẫn là tốt nhất. Thế còn khâu vòng cổ tử cung ấy thì cũng có trường mà chúng ta nên nhớ rằng là phải khâu đối với những bác sĩ phải có kinh nghiệm làm ở bệnh viện, có đủ điều kiện. Nhưng còn rất nhiều các bác sĩ vì không có kinh nghiệm do khâu vòng cổ tử cung cảm giác như là làm chít hẹp cái lỗ ngoài cổ tử cung, do khâu phải càng cao càng tốt. Trong một số các trường hợp mà vì nó quá ngắn và khâu ở vòng cổ tử cung ở đường âm đạo nó khó thì nên có thể là khâu eo ở cái đoạn qua cái nội soi ổ bụng. Tất nhiên là đòi hỏi phải rất có kinh nghiệm và kỹ thuật phải rất cao rồi mới có thể thực hiện được kỹ thuật đấy. Thế còn khi mà đã là có dấu hiệu sinh non rồi thì chúng ta nên sử dụng corticoid. Mà corticoid sử dụng vào lúc nào, vào thời điểm nào thì tiến sĩ Lê Quang Thanh cũng như phó sư tiến sĩ Shilpa Nambiar cũng đã nói rất rõ là phải để mà nó dự kiến được trước khi sinh. Nhưng các báo cáo viên cũng không nói thêm về cái tác dụng phụ của sử dụng corticoid. Nhưng tôi nhắc thêm là corticoid thì cũng đã có những nghiên cứu cho rằng là khi mà sử dụng corticoid để dự phòng sinh non khi cái thời điểm mà thai nhi còn rất ít tuần tuổi thai ấy, thì nó có nguy cơ là nó dính, nó liền cái khớp sọ rất sớm, do làm cho cái đầu của đứa trẻ nó cũng sẽ có vấn đề. Đấy là do đó cân nhắc cái chuyện có để có sinh non hay không để chúng ta sử dụng cái corticoid. Vì nếu sử dụng được corticoid thì người ta phải thừa nhận rằng là sau khi sinh đứa trẻ sẽ được điều trị ở phòng ICU, điều trị về hồi sức sơ sinh nó dễ dàng hơn, vì rằng nó làm giảm được nó làm tăng được cái xu hấp tăng, cái sức căng bề mặt của phế nang. Do đó là đứa trẻ nó cái tỷ lệ mà bị suy hô hấp vô căn đấy nó ít hơn. Do là người ta mới mạnh dạn sử dụng corticoid. Và đối với những cái trường hợp mà trẻ sinh non thì rất dễ bị tổn thương não, và do đó nên sử dụng Magnesium Sulfate dự phòng với liều cao. Thì như kinh nghiệm thì có thể dùng tổng liều là 4 gram một lần, phá thật loãng thì tiêm tĩnh mạch. Tại vì chúng ta mà phá mà đậm đặc một tiêm tĩnh mạch thì bệnh nhân để nóng bừng ấy, cả thứ do là cần phải phá loãng, và có thể chúng ta cân nhắc thêm lần nữa. Thì như vậy thì sẽ tránh được những cái trường hợp cái tổn thương não của trẻ sơ sinh non. Đấy là những cái nội dung rất cơ bản cần phải nắm trước khi mà hội thảo kết thúc. Tôi xin tóm tắt lại, và lần nữa xin trân trọng cảm ơn công ty Viet Healthcare đã tổ chức cái hội thảo cũng rất là quan trọng và rất là có ý nghĩa, giúp cho các bác sĩ chuyên ngành sản phụ khoa có thêm kiến thức, và cũng nhấn mạnh tại vì trước đây mà chúng ta không có những hội thảo như thế này, chúng ta cho rằng progesterone mà khi mà dùng cho những trường hợp thai đã ngoài 12 tuần, thậm chí có khi còn bị phê phán vì rằng progesterone nó chỉ có tác dụng hỗ trợ về mặt nội tiết thôi cho hoàng thể, và còn sau 12 tuần thì không còn có vai trò nữa. Nhưng ấy vậy, trong quá trình thực tiễn chúng ta thấy rằng không phải là chỉ riêng hỗ trợ của hoàng thể đâu, mà nó còn có nhiều tác dụng như như cái hội thảo mà chúng ta đã được nghe các bài báo cáo. Và nữa xin trân trọng cảm ơn các quý vị tham dự hội thảo hôm nay. Và tôi xin nhắc lại là vào tháng 10 thì tiến sĩ Lê Quang Thanh cũng đã có lời mời là sẽ có cái hội nghị Việt Pháp mà do Bệnh viện Từ Dũ đứng ra tổ chức. Còn vào tháng 11 nếu không có gì thay đổi, tình hình Covid ổn định thì Hội Phụ sản Việt Nam sẽ tổ chức hội nghị sản phụ khoa toàn quốc vào tháng 11 tại Trung ương Huế, tại thành phố Huế tươi đẹp. Xin cảm ơn tất cả quý vị.
Xin cảm ơn phần tổng kết của giáo sư Nguyễn Viết Tiến. Thì kính thưa quý vị đại biểu, thay mặt cho ban tổ chức chương trình, xin gửi lời cảm ơn chân thành đến chủ tọa đoàn và các báo cáo viên. Xin cảm ơn tất cả quý đại biểu, các bác sĩ và các bộ y tế đến từ khắp nơi trên nước Việt Nam, cũng như là một số bác sĩ từ các cái nước ở châu Á đã dành thời gian quý báu để tham dự cái hội thảo trực tuyến ngày hôm nay. Thay mặt cho Hội Phụ sản Việt Nam và Basin Healthcare, chúng tôi xin gửi lời chúc sức khỏe đến tất cả quý vị đại biểu và mong rằng trong thời gian sắp tới, công ty Basin Healthcare sẽ có nhiều cơ hội đồng hành cùng các bác sĩ trong chăm sóc sức khỏe sản phụ khoa nói riêng và công tác chăm sóc sức khỏe cộng đồng nói chung. Xin trân trọng kính chào và hẹn gặp lại.